Okay, so moving into my presentation, you know, I had an experience working as an architect for many years in practice. And one of the things that really fascinated me was how do we design for change? Because, you know, we are talking about digital transformation, but we have to realize that it's only another driver of change in healthcare. And we've been witnessing a lot of change over the last decade, a century. And when we think about how we design hospitals, we want them to last at least 50 to 100 years. That's considered to be best practice. And then we don't know what the future will bring. There is so much change that is coming. And one of the things that I realized is it's obviously not only change in technology, but it's also change in culture and social aspects. What do we expect of the hospital? What do we need in order to heal? We moved from designing hospital for process-centered care, really looking at them as factories, focusing on human-centered care, not only the patient, but also the caregivers and the family members. We moved from designing hospital to treat disease to health promotion all across the built environment. So not only the specific typology of hospitals, but how can we promote health through the whole built environment. We moved from designing mega hospitals, central mega hospitals, into community healthcare centers, which are in a human scale and connected to the place of living. And then we started developing smart hospitals, which I really like to do this comparative to how predictive, personalized, and precise medicine have been developed. Because if we know how to treat the patient precisely, then we should have the environment being tailored to the patient-specific needs. And for that, we need smart environments. I'm moving very fast because I want to get into the remote care. And then we have to recognize that one of the main drivers of change was that we realized that the patients are actually consumers. The patient will see you now. It's not that the doctor will see you now. And that's really a paradigm shift, which changed a lot of how we design for healthcare. And then the idea of healthcare without walls, that the hospital is actually without limits, because we can use remote technologies. I recently heard a new terminology which is called care without an address, which I also like. I think it's a different concept, but very similar to the idea of healthcare without walls. And then the recognition post-COVID that health should be made at home and hospitals will be only for repair. So hospital will become more acute and critical care, and everything else will move outside of the hospital into the community and the home of the patient. And this paradigm shift have really developed into a lot of new technologies. And this poster is from Israel, from just really early in COVID, where a lot of technologies, a lot of startups were developing remote care for different purposes. And I really like this poster because it shows that the boundaries between the hospital and the community and the home is now blurred. We don't really know where the patient is, where they are being provided with the care. And in many ways, maybe it doesn't even matter because you can connect remotely from different environments. And then it's all about building this relationship of trust, building the human experience, and seeing how the space really changes the way that we experience the care. I was really fortunate during COVID to be invited to participate in a multidisciplinary research led by the University of Cambridge. And I connected them with Sheba Medical Center in Israel, who have an innovation center in-house, which is called ARC. And here, similar to the 3 circles that I showed you before, it was a research looking at the intersection of healthcare, technology, and architecture. So more linking the different disciplines and trying to see how they really impact the idea of building a smart hospital of the future. And I think we had a kind of a aha moment. At least I had a aha moment when I realized that they were using telemedicine technologies not only to treat patients at home or far from the hospital, but also for inpatient care within the hospital. And again, it's a whole study. I won't go into a lot of details, but I want to share with you a few insights because I think it's really relevant to our symposium and our discussion, and for sure for the simulations later. What they did, they realized that because they don't have enough work power, they don't have enough nurses specifically, they wanted to divide the contaminated area with the patient with COVID from a clean area. So what you see in red is the contaminated area, and the blue is a control room where they integrated a lot of telemedicine technologies to treat the patients remotely. So the staff didn't have to put all the protective gear, all the PPE, and they can communicate with the staff working inside. Don't know. Yeah. And for us, it was incredibly interesting because they implemented the same model in 3 different units. In an ICU, which was developed in a parking garage, in an underground parking structure. So it was an open space. They also integrated it into an internal medicine unit, a typical unit with semi-private rooms. And then even for a closed mental health unit, which was really a challenge to treat patients remotely. And what we learned is that the space changed the model of care. It really evolved into a different model. Although they used the same technologies, it was the same concept, but it really evolved into different models based on the space and on the level of care. Obviously, if it's an ICU or internal medicine or mental health, it's a different care model. But just a few anecdotes from this study, which again, I think is relevant for what you will experience later. They used robots. So they had a lot of surveillance cameras, and they also use robots because they realized that they wanted to have communication in a eye-level height. So the surveillance cameras didn't really support a personal connection. But it took me some time over the observation to realize that it was only the men who were using the robot and only the high-level medical directors. So no female and no nurses were using the robot, only the director. In the ICU, they had a big window connecting the contaminated area and the control room. And although they had all the technology to communicate remotely, they used the window for physical visibility and used a lot of hand gestures because they couldn't hear each other. So the technology was not really supporting all their needs. They really need to be close to each other and communicate in an indirect way. There was a big challenge of spatial perception. So just imagine that you see a unit they have like 24 different rooms, and now something happens to one of the patients, and you have to realize where is that patient located, and where is the team, and where is the equipment, because all you see is a lot of those windows like we used to see on Zoom, right? And then you have to realize what is happening and where, because you have to manage this situation. So there was a big challenge of spatial perception. And they were innovative. Remember, it was a parking garage. So again, they came up with an idea to use a club car to drive between the patients, between the beds. And again, it was only the medical director and the head nurse who used it, because they didn't had to put all the protective gear. They can just go into this mini car and drive between the patients. And they had this speaker so they can communicate with the staff working inside. And then they even developed this car washing machine because it was contaminated. So before they went out of the car, they had to wash it so to be able to move outside. Another, I think, insight that was a surprise is that they used the technologies for safety control, for infection control. And when you think about, telemedicine was never designed for infection control. But what happened is that, unfortunately, I learned that a lot of the patients who died in the ICU didn't die from COVID. They died from other hospital-acquired infections. And if you can see here in this picture, there was you had to do 2 steps to move from one patient to the other. And they had to put above all their protective gear another layer, what you see in blue. And they forgot. Because again, the space didn't support the fact that you have to move outside of the room, change your gloves, change your outfit, and then move to the next patient. They were just doing 2 steps from one patient to the other. So they used the surveillance cameras to alert, to say, hey, pay attention. You just moved from this patient who has a contamination and you have to change your gloves. So it became a tool to assist them to manage the control infection. A lot of issues with privacy and I think dignity of patients. Because once you have those cameras to overview the patient, it's really a question of how you control, who watches, when do you watch, who can turn it off, when. Now, in our study, we were able to prove that the use of telemedicine technologies were really supporting the safety of the staff and the patient. It really helped them to provide a high level of quality of care. But on the other hand, it came with a compromise on the privacy of the patients. So how do you manage this? And one of the doctors actually came with, I think, again, an innovative idea that just like we have a physical curtain, when someone has to change their clothes or to have a personal treatment, you close the curtain. We should have a virtual curtain. So if there is an issue of privacy, you should turn on the virtual curtain to close the cameras, to control it. And then another, I think, a nice anecdote with the robot. One of the patients who was admitted in the ICU for a few months and was, how do you say, was sleeping? Forgot the name. No, not in a coma, but was in a serious condition, so he wasn't conscious, exactly. But he recovered, and after a few weeks that he was already in his home, he came back to visit with all of his families, bringing a lot of presents to the team. And they asked him, what do you remember from your period of time in the ICU? What do you remember? And he said, the only thing that I remember is really strange, is the nurse on skates. And it took them a while to realize that he was actually referring to the robot, because the robot was the only personal face that he saw. All the other staff members were wearing the mask, again with the PPE. They again came up with this idea to put stickers with their picture and their name so they can recognize each other. But the patient really didn't see a personal face. So the robot became more personal than the real staff. And I think, again, this is interesting to think about this change in our perception. Now, all I told you was related to COVID. But if you think of how we have been evolving since COVID, I think a lot of the things that we learned are still relevant. And if you think about the challenges that we are facing, we don't have enough staff, we don't have enough nurses and doctors, we are working in overcapacity. A lot of the ideas that were developed during COVID are still relevant when we think about the future. But in the post-COVID, what happened is that they developed a virtual hospital, which is called Shiba Beyond. They realized that by using remote technologies, that they can develop new models, new services. And they are using it, obviously, for consultation, for rehabilitation, clinics, online clinics. But what I find really interesting is home hospitalization. So how can you really provide acute care at the patient home and save the resources of the hospital and hopefully provide better care for the patient? So just to give you a few examples, they have home hospitalization for high-risk pregnant women. So women who are in high risk often have to be hospitalized for weeks, sometimes even months during their pregnancy. And, they leave their home, they leave their family behind, and they have to stay in the hospital for a very long time. Again, challenging with their work as well. And they realize that a lot of the monitoring they can do remotely. So what you see here is an ultrasound that can be used by the woman at home or at her workplace. Again, moving the place of providing care. And only if there is some deterioration, some critical condition, she has to come back to the hospital. This is really huge right now, providing mental care, remote mental care. You see here a clinic for mental care, but they also have home hospitalization for psychiatric patients who have to be admitted in a closed unit. And they realize that they can treat them at home. So just imagine, instead of being in a closed unit with all of the outcomes that we know how damaging it is for the patients and for the family, they can be treated at home remotely. And there is a lot of really impressive data on the quality of care that is provided at home. And then also for rehabilitation. So what I'm trying to show is that they have a lot of different uses. But I think what's really interesting is that we realize that it can also be for acute care. Not only for patients, with a flu that they can stay at home. It's really for acute care, not critical care, but acute care that can be provided at home. And we realize that what's happening is that the system becomes much more complex. So instead of having two options, either you're at the hospital, or maybe even one option, being at the hospital, now you can be either at the hospital or at the home, but the care can be provided physically, in person, or virtually, remotely. And here you can see the 4 different modes of delivery. Maybe I'll go through it because I think it's important. That the first one is inpatient hospitalization, the regular hospital treatment. The second is inpatient telemedicine, what I showed you with the COVID units, but again, an opportunity to develop this model also for the smart hospital of the future. Home hospitalization, where the doctor or the nurse come to the patient's home in person, physically, or it can be remote home hospitalization. And when we think about the patient journey, moving from different stages, from diagnostics to hospitalization, consultation, readmission, discharge, rehabilitation, so the continuity of care for the different stages of the journey, it can either be physical or virtual, right? On each stage, we can choose, should I go to the clinic or maybe I can have the consultation remotely? If I'm hospitalized, should the doctor come to my home or maybe I can communicate remotely? And also for the other stages. But it's actually even more complicated because it can happen at the hospital or at the home. So we have this complex system that is developing and a lot of choices to make. And then the question is, who is making the choice? Would it be the patient choosing? Do I want to stay at home or should I go to the hospital? If my mother has an appointment, should I take the day off to drive her to meet the doctor? Or maybe I can communicate remotely with the doctor and then tell her what he said, because that's much more efficient for me. Or is it really a clinical question? And in our study of again, acute internal medicine home hospitalization program, we realized that often the choice is not related to the clinical condition of the patient. So just to give you an example, and I apologize, it's small, in the diagnostic stage, they ask the patient to come to the hospital, not to be checked, but to actually explain how to use the technology, to give them the kit of the telemedicine devices, and to explain how to use it. And they usually ask the patient to come with a family member so they can educate them how to use the devices. So it's not really about the clinical aspects. And then for the hospitalization, I think, again, this was really interesting. You know how often at the hospital they have the doctor's round in the morning, moving from one patient room to the other, from one patient to the next. They ask the family to move outside of the room so they will have the privacy of talking among them, right? The doctor with the nurses, with the staff. And the family are moving outside. And then later they come to ask a lot of questions. But what happened when it was home hospitalization, they actually asked the family to be on the call. And then if you have a family member who's abroad, if the patient have a few children and they are not at the same location, you can have a team consultation. And the staff really want the family to be involved. So suddenly the position of the family, they become staff members. They have responsibility. They have to be part of the discussion, part of the decision making. So it really changes, it shifted the way we have the relationship between the different users. And then for readmission, they have like a fast track. So if a patient deteriorates at home, they don't have to go through the ER. They go directly to the same unit who is taking care of them. So now we are designing a new medical units with physical beds and virtual beds of patients at home. And then you have to manage how you move the patients from being in a physical bed to a virtual bed at their home, and maybe coming back to the hospital. So again, it requires a different approach on how you manage the unit. And then for rehabilitation, usually people come to the clinic every 2 weeks or every other week. And they have to tell the physician what was their experience at home. But now with the telemedicine technologies, there is constant monitoring. They have all the data of the period where the patient was at home, and it's much more accurate. It doesn't rely on the how the patient perceived it, but on real data, on monitoring throughout the rehabilitation process. But maybe for our perspective, what's really interesting is that we can have very diverse patient journeys, which can be tailored to the specific needs of the patient. So it's not, you know, one room fits, you know, everything is standardized, everything is the same. You can really tailor the care, the service, based on the patient needs, which are dynamics, and they change. To end, I would like to share with you a proposal that I was involved with a few colleagues from the Netherlands, Germany, and Norway to the Wolfson Economic Prize. I don't know if you know this, but they came up with this competition in 2021 on how to plan and design the hospital of the future. And it was, in a way, a response to the UK plan to build 48 new hospitals by 2030. A lot of money invested in it, a lot of resources. And they came up with this competition. Let's stop for a minute and think, what do we really need to build? And we actually argued that maybe we don't need to build so many new hospitals, but we have to think on how to build a system. And we came up with this idea. Again, it was a conceptual proposal to build, we called it Maya, my AI assistant, to give the patient the opportunity to choose where they want to be treated. So you can have all the different options, whether to go to the hospital, to stay at a home, maybe to go to a clinic. We had this nice idea of a care B&B. And then the patient is empowered by having the opportunity to navigate between different places of care, but also if he wants to do it virtually or physically. But it also required a system-centered design. How can we design the organizations to support it? It's not trivial, it's very complex, but I think there is a lot of opportunity here. But it requires the design of control centers, something that we see that is evolving and developing over the last couple of years. But just think of the flexibility that it can provide and the resilience in times of crisis. Like you can really use different places and different technologies to overcome lack of resources. And we try to show that, you know, at home I can have a consultation, remote consultation. I can be treated. We have already chemotherapy at home and dialysis at home. I don't know if you have it in Switzerland, but it's really a new development in Israel, I think also in the States. Just imagine when I'm very fragmented, I shouldn't go to the hospital to get chemotherapy. It would be much safer for me to stay at home and get the treatment. And then I can also, you know, have my exercise, again, health promotion also at the home environment. In the community, we called it the health house. We can have, again, a consultation with a physical nurse or doctor, communicated with someone remotely. Maybe there is an expert abroad that we can have a group consultation. I can have, similar to the idea of Maggie centers, I can have the social support of meeting other patients. We know it's really important and can help me through my healing process. And then, again, health promotion. We can have a nice information sessions, like cooking classes. But sometimes I have to go to the hospital when there is an urge, my condition deteriorates. I can stay overnight to be treated, and then I can, again, health promotion through the rehabilitation process. And what we try to show is that we have a lot of options. We can promote health, we can have consultation, or we can have treatment at home, at a community level, and also at the hospital. So again, we have this variety of options which are directed by using remote care. So just to conclude, a few things that I want to highlight. I really think that inpatient telemedicine holds value beyond COVID. We learned a lot, but in a way we moved back. So they put all those cameras in the patient rooms, and now they are not using it, or they took it off. And I think when you don't have enough nurses working in the unit, you have to develop this model and think on how you can use it to have a better quality of care. And maybe the patient can communicate with the family members at home while they're in the hospital. So just think of the potential that I think we haven't even started to realize, and we kind of put COVID away and not developed it further. Remote technologies enhance resilience during crisis. So what I try to show with the flexibility of having different options of managing resources, and especially manpower. An opportunity to transform hospitals into a healthcare ecosystem. I think we have to stop thinking about hospitals as a building, but as a system across the built environment. There is a potential to develop hybrid models integrating virtual and physical care. So again, we can meet physically and someone can join us virtually. This is something that we all know through our experience during COVID and in this era. But I think, again, there is so much opportunity to connect with the family members, to connect with other experts, to have integrated care. So if a patient has a heart condition, but he also has cancer, you know, they usually move from one specialty to the other specialty, and a lot of time the medication ruins the other treatments. It clashes, and the patient deteriorates because of that. So just imagine that the cardiologist and the oncologist can meet together and have holistic care for the patient. And then, and this is really related to the symposium, we have this opportunity, but I think also a responsibility to design remote care to enhance the experience of the users and to provide and maintain and even increase the quality of care. So thank you very much.